This slide depicts the process involved in peptide and free amino acid absorption. Peptides and amino acids are transported from the gut lumen to the small intestinal mucosal cells via two independent carrier mechanisms. It's important to realize that our bodies have more peptide carriers than amino acid carriers, and this directly relates to absorption. And as this diagram illustrates, peptides are more effective in getting more protein content into the portal circulation. This helps to improve nitrogen retention and absorption. In the child who presents with malabsorption, or in the child with a compromised GI tract, or even in the child who is in just a stressed state, all those individuals could benefit from a peptide-based formula rather than a free amino acid-based formula. Soy protein is another protein source that can be of benefit to some pediatric patients. Soy is used for a variety of reasons as an alternative infant formula choice to either breast milk or cow's milk-based formula. However, it should be noted that 10 to 50% of infants with milk allergy will also have a soy allergy. Soy is lactose-free, and some infants appear less gassy when switched to a soy formula. It's casein-free, as well as being a vegetarian-based milk, and it's supplemented to meet similar nutrient values of cow's milk. There are some concerns that soy protein is not thyroid-friendly, but studies on infants have not proven any adverse effects on the thyroid. MCT is rapidly hydrolyzed, and it is absorbed from the intestinal lumen into the portal bloodstream independent of bile and pancreatic lipase. And this is huge because, as we all know, that getting good fat absorption is part of getting good tube feeding tolerance. MCT can be helpful in some unique situations because it bypasses the lymphatic system, such as in the child with protein-losing enteropathy or the child that presents with chylous effusions. Both of these situations can be improved by providing optimal nutrition without adding an extra load to the lymphatic system. Children with special health care needs often present with bowel issues, especially constipation. Constipation, in turn, can negatively impact gastric emptying, thereby making reflux worse. A child's appetite can also be negatively impacted by infrequent bowel movements and can make feeding difficulties even more challenging. Many cases of constipation can be idiopathic in nature, although other causes also exist, which are structural or metabolic in nature. Common causes of constipation can be low tone, poor muscle coordination, inadequate fluid intake, inadequate fiber intake, or behavioral difficulties such as encopresis. So some solutions to common issues in the dietary treatment of constipation could include, first of all, meeting adequate hydration needs in the child who is having feeding difficulties. So for example, in the child who presents with feeding and swallowing limitations, especially with thin liquids, meeting hydration needs can be really difficult, and in some situations a G-tube might be necessary to be placed for meeting fluid needs in that child. Secondly, meeting adequate fiber intake. A lot of times we still use the age plus 5 rule, which means you take the child's age and you add 5, and that's your grams of fiber goal for the day. Fiber needs to really be introduced slowly and added into the diet in an acceptable way to the child, using high-fiber cereals, whole grains, fruits and vegetables, as well as fiber additives to beverages or purees can help. And it should be noted that this age plus 5 guideline might not be realistic, especially in a tube-fed child. Insoluble fibers are poorly fermented by the colonic bacteria in the human gut, and insoluble fiber adds bulk to the colonic contents. The more fiber, the larger the stool. It's the poorly fermentable insoluble fiber that provides the increased stool volume. And it is this increase in bulk that most likely affects intestinal transit so that peristalsis is facilitated and defecation is easier, better, faster, and more regular, which can then reduce constipation. Soluble fiber, on the other hand, soluble fiber is water-soluble, such as pectin, found in fruit, and it can be used to gel jams. Soluble fiber is quite viscous and can be easily fermented more quickly and completely by intestinal or the normal colonic flora bacteria when compared to insoluble fibers. In the stomach, soluble fibers become hydrated and tend to slow down gastric emptying time. This may be helpful in treating issues such as diarrhea or dumping syndrome. Soluble fibers are also unique in their ability to be fermented by colonic bacteria. And this is what we're going to focus on next as we discuss prebiotics. So a prebiotic is a non-digestible food ingredient that selectively stimulates the growth and or activity of one or a limited number of bacterial species resident in the colon, thereby beneficially affecting the host. Bifidogenic fibers are prebiotics, and they help promote the growth of good bacteria. Diarrhea occurs in ranges from 25 to 65% of patients receiving tube feeding, and that is awfully high. Therefore, finding some solutions that may be able to normalize stool output can really improve a child's quality of life that has these kind of issues. Prebiotics can help with water and electrolyte absorption. They fuel the colonocytes, and they impair the environment so that pathogenic bacteria have a hard time taking over. Prebiotics also help with constipation as they stimulate peristalsis and increase fecal moisture. All these benefits occur from short-chain fatty acid release, which is acetate, butyrate, and propionate. And these short-chain fatty acids cause that cascade of promoting good bacterial growth, filling in the water, and feeding the colonocytes, creating an environment which is not optimal for pathogenic bacteria, and stimulating intestinal peristalsis. So in conclusion, the enteral management of children with special health care needs requires a thorough nutrition assessment, a detailed diet history and current intake. We need to pay attention to all the nutrition needs, both macro and micronutrients, optimization of tolerance using knowledge of enteral formulas, focusing on the protein source and quality, the fat source such as MCT, the addition of fiber, and the availability of prebiotics, and close follow-up is necessary. So now I'm going to hand it over to Gail, and Gail's going to present our first case study.
Our first case study is for a 10-year, 1-month-old boy admitted to our pediatric long-term care facility from home. He was fed exclusively by G-tube. He has cerebral palsy, microcephaly, global developmental delays, and a seizure disorder. He's on Dilantin. When admitted, his weight for length was above the 95th percentile, but protein, fluid, calcium, zinc, and iron intakes were all inadequate for needs. On admission, the child weighed 64 pounds and was 48 inches tall. This put weight for length between the 95th and 97th percentiles. With a weight age of 9 years and 3 months and a length age of 7 years, there was a 27-month gap between weight age and length age. BMI was at the 85th percentile. Tube feeding on admission was 200 cc's of an intact protein pediatric formula with fiber, followed by a 100 cc water flush 4 times daily. He was also given 300 cc's of water with his medications by tube. When admitted, calorie intake was excessive for needs as evidenced by weight, but calcium, iron, zinc, and fluid were all inadequate. The nutrition goals for this child were to decrease calories to promote progress towards a weight in proportion to length and to boost protein, calcium, iron, zinc, and fluid up to requirements. The feeds were switched to a high 25% of calorie protein adult formula with fiber, and the calories were reduced by 10% daily to 4 180 cc feeds a day. A crushed multivitamin with minerals was added to boost zinc, iron, and calcium. 30 cc's of neocalglucan were added for an additional 690 milligrams of calcium. Water flushes were increased to 200 cc's after each of the 4 feeds. Following these interventions, intake of all major nutrients were met. The 10% calorie decrease resulted in stable weight. Stable weight concurrent with a 3-inch linear increase over 1 year resulted in progress towards weight in proportion to length. After 1 year, the gap between weight age and length age was reduced from 27 months to 12 months, and the BMI was between the 25th and 50th percentiles as compared to the 85th percentile prior to the intervention. We also separated the Dilantin administration from the tube feeding by 2 hours because the tube feeding reduces the bioavailability of the Dilantin. Finally, we separated the calcium and iron to maximize the absorption of both of these nutrients. Now Sharon is going to present our second case study.